Imagine, walking into a clinic on your lunch break. You get a quick cosmetic injection, maybe grab a comfy on the way out, and you're back at your desk for a 2 o'clock meeting.
Right, it's pitched as this totally seamless 30-minute touch-up.
Exactly. But beneath the skin, a microscopic boulder might have just been dropped into your bloodstream. And a countdown to permanent tissue death has literally already started.
It's scary how we live in this era where aesthetic enhancements are marketed as casually as a haircut.
Yeah, it creates this dangerous illusion that the human body is just, I don't know, a simple canvas you can tweak without consequences.
And the marketing language relies on minimizing the profound biological complexity that is sitting just millimeters beneath our skin. We're trained to view these rapid procedures as completely separate from serious medical interventions.
Right, that the biology doesn't care about the marketing.
Exactly. The body treats every single needle like an invasion.
And the moment that needle pierces the skin, you are interacting with an incredibly intricate, highly pressurized, and deeply interconnected vascular highway.
Which is why today's deep dive focuses on one highly specific, increasingly popular procedure. It's where that casual marketing collides with microscopic anatomy in a very intense way.
We are talking about the G-shot, otherwise known as G-spot amplification.
And while we are looking at this specific procedure, the mission of our deep dives today is highly focused.
We're exploring a rare but potentially devastating risk, right?
Yes, it's called localized tissue ischemia, or often referred to as filler-induced vascular occlusion, or FIVO. We really need to arm you, the listener, with the exact warning signs.
Like the physical red flags.
Exactly. We're talking about mottling, immediate blanching, and severe pain. Because if those signs are missed post-G-shot, it requires immediate emergency clinical intervention.
Okay, let's unpack this. We're looking at this intersection of aesthetic enhancement and vascular biology, which is simultaneously fascinating and honestly deeply alarming when you realize how delicate the system is.
Well, knowledge is truly most valuable when it's applied in the real world. Understanding not just that these complications happen, but diving into the cellular and vascular reasons why they happen is critical.
Because if you are going to alter the body, you must fundamentally respect the architecture of the body.
Precisely.
So let's start with the mechanics of the G-shot itself. From a procedural standpoint, it's pitched as a quick fix with virtually no downtime.
Right, they say you can go right back to work.
Yeah. So the practitioner injects about 2 cc of hyaluronic acid filler, which is the exact same kind of dermal filler used to plump up lips or cheeks, directly into the anterior vaginal wall.
Right between the bladder neck and the vagina.
Right. And the goal is to physically enlarge the G-spot to about the size of a quarter to enhance sexual pleasure and sensitivity.
The hyaluronic acid essentially acts as a volumizer. It's a gel that physically plumps the tissue.
But the hidden danger here lies in the pathophysiology of the vascular occlusion.
Because the vaginal wall, particularly the anterior wall where this is injected, isn't just empty space.
Yeah.
It's a densely packed, highly vascularized network of arteries and veins.
Right. And when you introduce a synthetic gel into that specific environment, an occlusion can occur via 2 primary mechanisms, right?
Yes. The first is intravascular embolism, and the second is extravascular compression.
Let's break those down. Intravascular embolism is basically when the sharp needle, or even a microcannula, accidentally punctures the wall of a blood vessel.
It pierces right through.
Yeah, and the practitioner, without realizing it, inadvertently injects the hyaluronic acid gel directly inside the vessel itself.
Which causes an immediate blockade. It's instant.
But the second mechanism, extravascular compression, is a bit more insidious.
It really is. Hyaluronic acid is incredibly hydrophilic. That means it aggressively attracts and holds on to water molecules.
So even if the practitioner has perfect aim and doesn't inject directly into a vessel.
Exactly. That filler sits in the tissue, draws in surrounding fluid, and slowly expands over hours or even days.
To put a visual on this, think of the vascular system as this perfectly balanced network of one-way streets and narrow alleyways.
I like that analogy.
The intravascular embolism injecting directly into a vessel is like dropping a massive boulder right into the middle of a narrow alleyway. The traffic, the blood flow, instantly stops.
Boom. Complete stop.
Right. But for extravascular compression, it's not a boulder. It's more like someone planted a massive, dry sponge in that narrow, brick-walled alleyway and then turned on a hose.
Oh, that's a great way to picture it.
The sponge swells and swells relentlessly until it completely crushes the pipes and roads running next to it.
If we connect this to the bigger picture, the downstream effect of both scenarios is identical. The surrounding neighborhoods, the tissues that rely on those streets for oxygen and nutrients, immediately begin to starve.
Because the blood can't get through.
Right. That starvation of oxygen is what clinicians call ischemia. The tissue is literally being choked.
Wow.
And the moment that oxygen supply is cut off, it sets off a very literal ticking clock for the survival of that tissue.
Which brings us to the early warning signs. If that clock is ticking, you need to know exactly what the alarms sound like. If someone gets this procedure, what is the absolute first red flag that something has gone wrong?
The very first immediate sign of ischemia is blanching.
Blanching. Okay.
Because the blood supply has been completely cut off, the tissue in the affected area will immediately turn pale, white, or take on a dusky grayish
It
appearance.
just loses all its color.
It happens almost instantly as the blood drains out and isn't replenished.
And there's a specific physical test the practitioner should perform right then and there to confirm it, right? The capillary refill time.
Yes, capillary refill is a fundamental clinical test, and it's something you can visualize right now. If you're listening to this, press firmly on the back of your hand or your fingernail.
Just push down until it turns white.
Exactly. You force the blood out and the skin turns white. When you release the pressure, that pink color should return in 1 to 2 seconds.
Because the blood rushes back in.
Right. That rapid return of color proves your microvascular network is functioning and pushing blood back into the capillaries.
So if a practitioner presses on the mucosal tissue right after injecting the filler and they let go, and it stays white for 3, 4, 5 seconds.
That indicates blood flow is severely restricted. It is a massive clinical red flag. If it takes longer than 3 seconds for the color to return, you are likely looking at an occlusion.
But here's where I want to push back on standard medical advice.
Okay, go ahead.
We know that severe pain that is completely disproportionate to a normal tiny needle prick is a hallmark sign of a vascular occlusion.
Absolutely.
It makes sense, right? Your tissue is suffocating. It's going to send a massive pain signal to your brain. But wait, the clinics providing the G-shot explicitly advertise that they use topical numbing creams and strong local anesthetics before they inject.
They do, yes.
Doesn't that completely mask the pain signal? I mean, if the area is numb, how is the patient supposed to feel the disproportionate pain to warn the doctor?
You've just hit on a critical and incredibly dangerous paradox in modern aesthetic medicine. The routine use of local anesthetics, like lidocaine, absolutely masks that early warning sign of severe pain.
So they might not feel anything is wrong at all.
Right. The patient might feel pressure, but they won't feel the sharp, agonizing burn of ischemia. Furthermore, many of those local anesthetics are formulated with adrenaline or epinephrine.
Which restricts blood vessels to prevent bleeding during the procedure, right?
Exactly. Epinephrine is a powerful vasoconstrictor. It naturally causes the tissue to temporarily pale or blanch.
Wait, really?
Yes. So you have a situation where the anesthetic hides the pain and the adrenaline mimics the visual sign of the tissue starving.
That is terrifying. So the numbing cream not only silences the alarm, it actively camouflages the visual evidence of the emergency.
Because of this paradox, relying strictly on visual cues and rigorous physical tests becomes incredibly urgent for the clinician.
They really have to be paying attention.
If the patient can't feel the pain, the practitioner's eyes and hands are the only things that can catch the occlusion. They have to rigorously check for that sluggish capillary refill or note if the tissue feels abnormally cool to the touch, which happens when warm blood stops flowing. It requires hypervigilance.
Here's where it gets really interesting, though. Let's look at the delayed reality. What happens if those subtle early signs are missed?
Which happens, unfortunately.
Right. The patient is numbed up, the procedure is over in 10 minutes, there's no immediate pain, and they are sent home thinking everything went perfectly.
If the immediate signs are missed, we move into the delayed signs of ischemia, which typically appear minutes to hours later, often after the patient has left the clinic.
Oh, wow.
The hallmark of this secondary stage is something called levato reticularis.
Levato reticularis. It sounds like a spell from Harry Potter, but it's actually this very ominous visual warning. It's described as a mottled, net-like, reddish-blue pattern spreading across the skin or the mucosa.
That mottled, net-like appearance is caused by deoxygenated blood pooling and becoming trapped in the starving tissues.
Because it can't escape.
Exactly. The oxygen had been fully consumed by the cells, fresh arterial blood can't get in because of the blockage, and the old blue venous blood can't get out.
So it just sits there.
It creates this distinct web-like bruising. It's a sign of profound vascular distress. And if this stage is ignored, the timeline becomes incredibly grim.
Walk us through that timeline. How fast does this progress from bruising to permanent damage?
By day 3, the starving tissue will begin to fundamentally break down, forming painful blisters.
Blisters inside the tissue.
Yes, the structural integrity of the cells is failing. By day 5, if there is still no intervention, the area progresses to coagulative necrosis,
Which is outright tissue death.
complete tissue death. It leads to Escher formation, which is the thick, black, crusty scarring of dead tissue.
God, that sounds awful.
Once you reach necrosis, the tissue is gone. It will not recover. It has to heal by secondary intention, which essentially means the body has to slowly fill in the dead crater from the bottom up, leaving permanent severe scarring and loss of function.
To really illustrate the ultimate danger of pelvic vascular occlusion, we need to look at an extreme case study. Because this isn't always just about a small, localized blister.
No, the systemic risks are very real.
There is a documented, stark case report involving a 38-year-old woman that shows exactly how interconnected the system is. Over the course of 7 months, she received a massive 47 milliliters of hyaluronic acid filler injected into her vaginal wall across 4 sessions.
Wow.
And then she went back and received an additional 15 milliliters in a single 5-minute session.
Which is an astonishing, almost incomprehensible volume when you consider a standard G-shot is roughly 2 milliliters.
20 minutes after leaving the clinic, she experienced sudden palpitations, extreme dizziness, and collapsed.
It hit her that fast.
She was rushed to the emergency department, deeply cyanotic, turning blue, and struggling to breathe. The doctors initially treated her for anaphylactic shock, thinking it was a severe allergic reaction, but none of those treatments worked. She went into ventricular failure, multiple organ failure, and tragically passed away 10 days later.
It is a devastating outcome, and the subsequent autopsy results are vital for understanding the underlying mechanics of pelvic injections.
What did they find?
When pathologists examined the tissue, they found that the sheer volume and pressure of the filler had forcefully embolized into the paravaginal vessels. But the critical finding was that it didn't stay there.
It traveled. It didn't just block the local alleyway.
It traveled extensively throughout the venous system. They found the synthetic gel had extended from the vaginal submucosa all the way to the rectal mucosa.
That's a huge area.
It had infiltrated the large paravaginal veins and the smaller submucosal veins, creating a massive cascading blockade.
So going back to our traffic jam analogy, the boulder broke apart and was carried through the underground tunnels, blocking the major highways and the surrounding city grids all at once, eventually impacting the heart itself.
That perfectly captures the pathophysiology. This extreme case illustrates how deeply interconnected the pelvic vascular network is.
It's all linked together.
The vessels in the anterior vaginal wall don't exist in isolation. They communicate directly with the vessels supplying the bladder, the rectum, and eventually the major venous returns that go straight to the heart and lungs.
While a 2cc G-shot is vastly smaller than the 15cc that triggered this fatal event, the biological principle remains identical, right?
Exactly. An embolism in this highly vascularized region doesn't just stay put, it can propagate. Recognizing early ischemia isn't just about preventing a local scar. It is quite literally a matter of life and death.
Okay, so let's pivot to the rescue. Let's say the clinician catches it. They see the blanching, they notice the capillary refill is taking 4 or 5 seconds.
Or the patient calls them 2 hours later saying they have severe disproportionate pain breaking through the numbing cream, and they see that weird blue net-like mottling.
The traffic jam has happened. How do we reverse it?
The immediate protocol demands rapid, decisive action. First, stop the injection instantly.
Pull the needle out.
Well, actually, the clinician will attempt to aspirate Bertie, pull back firmly on the syringe plunger to see if they can manually pull any of the filler out of the vessel. Though honestly, this is rarely successful.
Makes sense. It's pretty thick gel.
Next, they apply warm compresses and vigorously massage the area. The heat and the physical manipulation are an attempt to force the blood vessels to dilate and mechanically push the obstructing gel out of the immediate bottleneck.
There's also the immediate administration of aspirin, usually around 325 to 625 milligrams. Why aspirin?
The aspirin is a crucial preventative measure. When a blood vessel is injured by a needle or blocked by a foreign substance, the body's natural defense mechanism is to send platelets to the site to form a blood clot to stop perceived bleeding.
But you already have a blockage.
Exactly. In this scenario, adding a natural blood clot on top of a synthetic filler blockage will only make the ischemia exponentially worse. The aspirin prevents platelet activation, It stops the body from compounding the traffic jam.
But the warm compress and the aspirin are really just buying time. They don't remove the boulder. The ultimate weapon, the true reversal agent, is an enzyme called hyaluronidase.
Hyaluronidase, often abbreviated clinically as hyalin, is the definitive treatment. It is an enzyme that specifically breaks down and dissolves hyaluronic acid filler on contact.
Like a chemical drain cleaner for the veins.
Sort of, yeah.
Yeah.
But you can't just inject a tiny drop, pat the patient on the back, and hope for the best. The emergency clinical guidelines require a high-dose pulsed approach.
Walk us through that. What does a high-dose pulsed approach actually look like in practice, and how does the enzyme reach filler that's trapped inside a blood vessel?
The practitioner essentially has to flood the entire ischemic area. We call this area the affected angiosome, which is essentially a specific 3D block of tissue that is fed by one main source artery. The protocol calls for injecting 1,500 units of hyaluronidase every 15 to 20 minutes directly into that angiosome. They inject it peravascularly, meaning all around the outside of the vessel.
But how does it get inside to the filler?
And that's the fascinating part. Studies show this specific enzyme is permeable. It can actually soak through the vessel wall and dissolve the filler trapped inside.
Oh, wow, that's amazing.
You keep administering these massive 1,500-unit pulses every 20 minutes, observing the tissue, until you see the capillary refill time normalize and that healthy pink color return.
But what if it's too late for just the enzyme? What if the patient comes in on day 3 or 4, they didn't know what levodoreticularis was, and the tissue is already breaking down and entering that blistering necrosis phase?
Once tissue starts dying, simply removing the blockage isn't enough. You have to rebuild the road. That requires a much more comprehensive regenerative approach.
Which brings us to a specific protocol.
Yes, there's a newly developed rescue protocol called this and FAT, an acronym for a highly advanced multi-step salvage operation.
Okay, break down the mechanics of this and FAT for us. How does this save dying tissue?
The T stands for toxin, specifically botulinum toxin, widely known as Botox.
Wait, Botox? I thought that was strictly for freezing wrinkles. How on earth does freezing a muscle help a blocked, starving blood vessel?
It's a brilliant off-label application. In severe ischemic events, the blood vessels surrounding the blockage often go into severe vasospasm.
Like they're cramping up.
Exactly. It's an involuntary panic signal. The sympathetic nerve conduction fires repeatedly, causing the arteries to clamp down tightly, which actually worsens the lack of oxygen.
Wow, the body is working against itself.
Botulinum toxin, when injected into the surrounding area, blocks that specific nerve conduction. It essentially turns off the panic signal, forcing the smooth muscles in the arteries to relax and dilate, allowing whatever collateral blood flow is left to reach the starving cells.
That is incredible, using a paralytic to force the vessels to relax.
Okay, so T is toxin. H is for the high-dose hyaluronidase we just discussed, to ensure every last microscopic drop of filler is dissolved. I and S stand for injectable and serum platelet-rich fibrin, or PRF.
That's that.
The clinician draws the patient's own blood, spins it in a centrifuge, and extracts the fibrin.
And what is the fibrin doing in the wound?
It is densely packed with concentrated growth factors. When injected into the dying area, these growth factors physically stimulate angiogenesis, the rapid creation of brand new blood vessels, to bypass the dead zones.
That is wild. And the FAT portion of the acronym?
That involves harvesting the patient's own fat, usually from the abdomen, processing it down into liquefied nanofat, and injecting it directly into the necrotic wound. Sometimes they even suture a thin membrane of this fat directly over the dying tissue.
Why fat, though?
Fat tissue contains incredibly high levels of regenerative stem cells. When you inject that nanofat, those stem cells act like microscopic construction workers.
Oh, I see.
They don't just sit there. They actively read the chemical distress signals of the dying tissue and begin rapidly laying down new cellular matrix to literally rebuild the destroyed mucosal barriers from scratch.
I do have a question about a different treatment, though. I've seen some clinic brochures suggesting the use of nitroglycerin paste, the same ointment used for heart patients having angina, rubbing it on the skin to open up the blood vessels. Sounds illogical, right? If the vessel is blocked, open it up.
This raises an important question, and it sounds highly logical, which is why it was recommended as a first-line treatment for filler occlusions for a long time. Nitroglycerin is a powerful vasodilator.
But I sense a massive however coming.
However, the recent literature is highly conflicted, and many expert consensus groups now strongly advise against it. An important physiological study using animal models demonstrated that applying nitroglycerin paste did not improve tissue perfusion.
Really?
In fact, it made the tissue look more congested and actively worsened the clinical outcome.
Why would opening the vessels make the starvation worse?
Think back to our boulder in the alleyway. The boulder is lodged tightly. If you suddenly use nitroglycerin to widen that alleyway just a little bit, the boulder doesn't magically disappear.
It just rolls further down.
Right, it gets dislodged, pushed further down the street by the blood pressure into a smaller, narrower set of microcapillaries where it becomes even more deeply, permanently lodged.
Yeah, wow, that makes perfect sense.
Dilating the vessels might just push the obstructing filler deeper into the vascular bed, vastly worsening the ischemia. Furthermore, nitroglycerin can cause systemic drops in blood pressure, leading to fainting and shock for the patient. The risks heavily outweigh the theoretical benefits.
So what does this all mean? If you're listening to this and you're wondering what this all means for you, it comes down to a radical shift in perspective.
Absolutely.
If we zoom out from the centrifuges and the stem cells, we are looking at an industry that markets procedures like the G-shot as simple lunchtime enhancements. But the reality is that the pelvic region, and frankly the human face as well, is a dense, exquisitely sensitive vascular web.
It really is.
If you ever consider undergoing a hyaluronic acid filler procedure, you must memorize the warning signs of localized tissue ischemia. You are looking for severe, disproportionate pain that cuts right through the numbing cream.
And you're looking for immediate pale blanching of the tissue.
Right. You need to know about a sluggish capillary refill taking longer than 3 seconds and that delayed blue and red net-like mottling of levato reticularis.
Knowing the science isn't about fear. It empowers you to advocate for your own body. Before any needle touches your skin, you need to ask your practitioner directly if they have a written emergency protocol for vascular occlusion.
Exactly, be direct.
You need to ask them if they have high-dose hyaluronidase physically present in the clinic, right in the room, ready to be drawn up. If they don't, or if they dismiss the risk as impossible because they are highly experienced, you are in the wrong clinic. You walk out.
It leaves you with a really profound final thought to ponder. As aesthetic medicine rapidly normalizes the injection of synthetic gels into our most sensitive, highly vascularized tissues, we have to ask, are we outpacing our own understanding of human microscopic anatomy? If a simple 30-minute cosmetic tweak can trigger a microscopic boulder that cascades into total tissue starvation, perhaps our modern definition of minimally invasive needs to be completely rewritten, because down at the cellular level, there is absolutely nothing minimal about it.